All right. Hi, everyone. I am Deanne Mazzochi, State Representative for the 47th District in the state of Illinois. The Illinois House District 47, it encompasses Elmhurst, Oak Brook Terrace, Hinsdale, Clarendon Hills, Westmont, a little bit of Western Springs, Willowbrook, and Downers Grove. So we're, and if I've left anybody, Clarendon Hills, can't forget Clarendon Hills. So we are very grateful that you've joined us. If you're here with us live tonight, you can also rewatch this later on. We're going to keep posts on Facebook, and you'll also be able to find this webinar at repmazzocchi.com. So one of the things that I wanted to do for everyone in the district was to present some COVID clinical updates. We're very lucky here in the state of Illinois that we have some incredible research going on in the city of Chicago, in particular at the University of Chicago. And I've had the pleasure of working with several experts from the University of Chicago over the years. And one of them is here with us today, Dr. Mark Ratain. And they're going to be talking to us about some of the innovation and research that has been going on at the University of Chicago to try to go after COVID. So if I can introduce our two educators for you. So the first is Dr. Mark Ratain, the Leon Jacobson Professor of Medicine and Director for the Center of Personalized Therapeutics. He's an expert in the use of investigational agents to treat advanced solid tumors and also has a special interest in pharmacogenetics, the study of how genetic variation affects the body's response to medications. Dr. Ratain's research focuses on the development of new drugs and developing diagnostic tests to create individualized therapies based on each person's genetic makeup. He's an international leader in phase 1 clinical trials, pharmacogenetics, and clinical trial methodology. He has more than 260 original publications, leads the University of Chicago's phase 1 oncology trials program, serves as the director of the Center for Personalized Therapeutics, and chief hospital pharmacologist for the entire University of Chicago Medical Center. He's also the co-chair of the Pharmacogenomics of Anti-Cancer Research Group, which brings together teams of experts from across the nation to investigate advancements in pharmacogenomics. We also have with us Dr. Bhakti Patel, a pulmonologist and authority on non-invasive therapies that prevent long-term complications in patients on ventilators, which obviously is a huge issue for COVID patients. Dr. Patel's research finds that keeping patients alert and breathing on their own provides numerous benefits over ventilators. Her research has been cited in numerous clinical studies and is often incorporated into treatment of patients in respiratory distress. And some of her innovative research has done much to keep COVID patients alive and off ventilators. So we're very grateful for that. As a researcher educator, Dr. Patel has published numerous articles and book chapters, lectured extensively at national scientific meetings, and her work was selected for the top 10 Clinical Research Achievement Awards in 2016, earning her the Distinguished Clinical Research Achievement Award. So welcome to our University of Chicago expert panelists. So the way in which I thought we would start off is I'm going to give everyone just a few background statistics of where we are with COVID-19, and then I'm going to turn the floor over to the doctors. So when it comes to COVID-19, one of the things that we currently know is that there have been considerable fatalities associated with COVID-19. The graphic that I have here on the third slide, I hope you can see it. I think maybe part of it's in, there we go. Part of it's in view. Make sure we're going back to the prior page. And then this just demonstrates that while you can see that we did have a large spike in the March, April, May timeframe, but fortunately our total death count in the state of Illinois has been going down to hopefully historical norms. One of the other pieces of data that I do want to reiterate is that COVID-19 is impacting particular patient populations who are very vulnerable. If you look at the state of Illinois cases, and this data is from the Illinois Department of Public Health, we can go to the next slide. You can see that while we have a little bit of a bell-shaped curve in terms of people who are getting infections, starts at those who are under the age of 20 and goes up to those who are over the age of 80, you've got a decent distribution of where the infections are, but obviously the fatalities are certainly at the upper end of the age scale. And we can also see on the next slide that when it comes to residents in long-term care facilities, While they have been about 18.6% of the cases, they've been closer to 76% of the fatalities in DuPage County. So against that background, this is one of the reasons why I think everyone is very interested in understanding what is going on with COVID when it comes to, if I am infected, what are the options that I have available? So with that, I'd like to turn the floor over to Dr. Ratain, who's going to go through what's coming down the pipeline and what we have available in terms of treating patients who are COVID positive. Dr. Ratain?
Thank you very much, Dan. First of all, I really want to thank you and the audience for allowing the University of Chicago Medicine to participate in a DuPage County event. And we certainly welcome patients from DuPage County. And if anybody has any problem getting into our institution, please either contact me or contact Representative Mazzochi, and we'll get you into our institution. So I promise you that. If we go to the next slide, it's amazing what one can learn in less than a year. This is obviously all new. And as you heard, I'm neither a pulmonary physician nor an infectious disease physician. I'm a medical oncologist, a cancer physician, and I've spent the vast majority of my career developing new drugs for cancer and doing clinical trials. And it turned out, of course, that nobody was an expert in COVID in early 2020. And in March, we realized we better start worrying about this. And as the pandemic hit the United States and the Seattle area, we began immediately saying we've got to get some things going. And first thing we reached out for were treatments for patients that were hospitalized. And there was a drug, an investigational drug at the time, remdesivir, that is a drug that is manufactured by Gilead. It now has some manufacturing partners, and there had been some limited experience in China. And there were two trials, actually three trials being started. One trial being started by the National Institute of Health. That trial was randomizing half the patients to receive remdesivir and half the patients to receive a placebo. And then Gilead itself was sponsoring two trials for patients that were hospitalized with remdesivir. But in the Gilead trials, particularly for the sick patients, if you required oxygen, in the Gilead trial, you got a 100% chance of getting remdesivir. In the NIH trial, you had a 50% chance of getting remdesivir. And while a placebo-controlled trial may be optimal scientifically, we were interested in getting what was best for our patients. And so we went with the Gilead trial. The trial was enrolling patients. Everybody got remdesivir. Half the patients received the drug for 5 days in the hospital, half received the drug for 10 days in the hospital. We were the second US site into the trial, I believe, and we were the second highest enrolling institution in the country with over 200 patients enrolled, thanks to a heroic infectious disease team led by Dr. Catherine Mullane. So that was a terrific effort, and I believe it's got a significant role in keeping our mortality rate down. Now, you'll hear from Dr. Patel about what happens when people end up in the intensive care unit, but we were really trying to keep people out of the intensive care unit. And so another drug that we began studying very quickly was a drug called Tocilizumab. It's primarily marketed in this country and elsewhere for rheumatoid arthritis. And it's given to outpatients with rheumatoid arthritis, usually as an intravenous infusion every 4 weeks. And we recognized that this was a great drug for COVID. There was some preliminary data, again, out of China that we were relying on, but we realized that we didn't need to give the full dose of this drug, that we didn't need to treat a patient for 4 weeks and suppress the immune system part of the disease. And so we really here, we're trying to prevent what's called the hyperinflammation phase, where one's body just turns on a inflammatory response, trying to be helpful, but actually in many patients, killing the patient. And as you'll hear from Dr. Patel, this is a very complex syndrome once it gets to the intensive care unit. And so we began using low doses of tocilizumab. The other strategy that there's been some experience with is convalescent plasma transfusions, where one collects plasma from patients who have recovered and administers it to other patients. There are also many investigational drugs in development, although I think we have a pretty good tool chest. And the one drug that's been proven to reduce mortality is a cheap, commonly prescribed steroid, dexamethasone. However, it's not clear how to optimally use this drug. The study that showed that it reduced mortality was conducted in the United Kingdom in patients that were not receiving remdesivir. And in the patients who got dexamethasone, the mortality rate was 22%. In our patients at the University of Chicago overall, hospitalized patients, mortality rate was about 10%. So it's hard to know what to do with dexamethasone. Clearly, it's a good drug if you have nothing else to use, but no one's certain as to the best time to use it. Of course, we'd like to keep patients out of the hospital, and there's strategies in development, but as yet, there's no established treatment for that. There is some evidence that a drug used for multiple sclerosis, interferon beta, may be effective in early disease, and there's great interest in developing oral drugs. And then finally, another important component is giving blood thinners, particularly in patients who move on to an intensive care setting, the drug heparin. So we've made significant progress in treating this disease. Patients are still dying, however. And what we really want to do is prevent this disease with a vaccine. I don't know when and if that's going to happen. The other concern that I have, and we're beginning now to think about the best way to manage this, are the post-COVID complications, what some are referring to as long-haul COVID. And again, we don't really understand this, and we certainly don't have treatment for it. So, so that's where we are with COVID at the University of Chicago in August of 2020.
And Dr. Tang, can you disclose what clinical trials the University of Chicago currently has going on that's on the drug therapy side?
On the therapy side, we're working, our major interest is probably with a trial with Eli Lilly. Dr. David Pitrak, who's chief of our infectious disease section, is running that trial in collaboration with Eli Lilly, and this is a monoclonal antibody therapy, which is of high interest to many. And the nice thing about this, it just requires a single dose if it works. And so that would be certainly much easier than any of the therapies we have right now.
And the monoclonal antibody, was it based on any one particular, like, is it being the types of, like a particular patient source, or is it one that was actually genetically engineered to target the particular spike protein?
This is a genetically engineered monoclonal antibody, and there's a number in development. A number of companies are using this strategy, and it makes perfect sense that one can take a monoclonal antibody and neutralize this virus. And so I think there's a lot of optimism around this strategy, but as yet no one has proven this works.
And what stage are the clinical trials at University of Chicago? Phase 1, phase 2, phase 3?
This is a phase 2 trial at the University of Chicago, but some patients are getting placebo, but most patients are getting one of several doses of the monoclonal antibody.
So that's pretty far along. And one thing for our listeners, just so you know, if you want to ask the good doctors a question, there is a Q&A function in the Zoom chat. Feel free to throw a question in there as we go along if you want to ask questions. One thing, Dr. Tang, I did want to follow up on is you did mention that there's a desire for oral drugs. Obviously, they're easier to administer. It's easier to have patient compliance versus having to dose by IV. Of the drugs that have been used somewhat successfully so far, are there any of them that are oral, or for the most part, are they all IV administration?
I have not seen any good data for any oral drug as yet.
Okay. And one thing I do want to let people know is we did do a webinar as well with some of the pharmaceutical companies who were talking about some of their therapies that are coming in down the pipeline. So there's not only great things going on at the University of Chicago, but also nationwide. So with that, I'd like to next turn to the next slide and Dr. Patel to kind of go through what her experience has been on the clinical patient side, and in particular, trying to keep patients off of ventilators.
Thank you, Representative Mazzochi. I'm Dr. Bhakti Patel. I'm an ICU physician. And as you probably heard, as the pandemic was hitting the United States, there was a lot of concern that we would not have enough ventilators for patients when they needed them. And that problem was arising for two reasons. One is that patients who have COVID infection, if they start having symptoms that are severe enough to be hospitalized, about 1 in 20 would need the ICU. And then once they entered the ICU, half of them were needing a ventilator. And because of that, the sheer number of patients who could get infected and then need hospitalization, we're really worried that we had a limited number of ventilators. And then that problem got compounded because we didn't really understand what's the best protection for healthcare providers so that as they care for these patients, they don't get ill as well, because the providers were also going to be another precious resource. And so the typical tools that we use to prevent people from needing a ventilator included special kinds of nasal cannulas where it gives oxygen at high flows, or special masks that cover the nose and the mouth, similar to what you might use for sleep apnea. Those sorts of tools that you use to prevent people from needing a ventilator were not being chosen for patients who had COVID because they could aerosolize all the breath that the patient had and maybe infect the providers. And so the threshold to put someone on a ventilator was lowered. And so not only were we putting people on ventilators because they were sick, we just were putting them on them because we didn't have the tools that we needed. So at the University of Chicago, we were sort of the only institution in the country that had experience with other ways to give patients oxygen without a ventilator. So 4 years ago, we did a clinical trial where we took patients who had bad pneumonia, needed high oxygen levels, who were on a mask to deliver that oxygen, but it seemed like it wasn't sufficient. And then we randomized them to continue on the mask or switch over to the helmet. And you can see a photo of that here. The helmet is a clear, transparent hood that goes over the head of the patient. The seal is at the neck. And so you can deliver oxygen at higher pressures and perhaps open up the lungs so that the body can get the oxygen that it needs. And our hypothesis was that using this device was more effective because you could deliver oxygen at higher pressures to patients without a lot of leak, was a bit more comfortable, and patients would tolerate it for longer periods of time without needing a ventilator. And what we found was that we could reduce the number of patients who needed a ventilator from 60% with a traditional mask to 20% with a helmet. And avoiding the ventilator also seemed to save lives. So those patients who received the helmet had a 22% increase in their chances of surviving, which meant that if we gave 5 patients a helmet, we could save 1 life. And this device became of particular interest because we knew that because it's a hood that covers the head and the seal is at the neck, and the seal was had high fidelity where it wouldn't leak a lot, that we could give it to patients with COVID without potentially infecting or the providers or exposing them to the virus. And so we started using helmet ventilation for patients who were in the ICU with COVID. In addition to other tools, we also changed the environment in our hospital where we could extend and create more ICU beds and make sure that the air that is circulating in the rooms and in the hallways was exchanged at higher rates. So the chance of circulating virus in the air was quite minimal. And by using these devices, we were able to substantially reduce the number of patients who needed a ventilator from what typically was touted as about 50% of the time to down to maybe a quarter of the time or less. And sparing the ventilators, we found, also meant that patients could be awake, they could interact with their providers, get out of bed, not have so much difficulty with loss of strength because they were bedbound. And also they were of sound mind because they could interact with people and not be under sedation while they're on a ventilator. And so we found that those patients who received helmet and did well actually had a higher chance of actually going home as opposed to some other rehab facility to continue their recovery. So I think some of the innovations at University of Chicago were an ability to sort of think creatively to this problem, where when we could typically rely on our tools and just say, well, let's just put them on ventilators just to be safe. I think we thought that, ventilators are not necessarily a benign intervention. They do come with some risks. And if we could safely prevent people from needing them, we could spare ventilators for patients who really needed it. And that's been quite rewarding to see that work make a difference for the patients who've been hospitalized here.
And one of the things, just looking at the helmet design that you have here in the photograph, obviously ventilators are extremely complicated pieces of machinery. This is obviously a much simpler, more elegant design, but from a manufacturability perspective, I'm assuming this is something that's far easier to manufacture or scale up if you needed to, as opposed to ventilators.
Yeah, and it hooks up to the regular oxygen in the room. And so it can inflate the helmet and you can set a valve on it to set whatever pressure you want. So we had found ways to even hook it up with basically MacGyvering oxygen tubing and not using any sort of advanced technology. And at the time when we did our study, it was a small mom and pop shop that was making these devices out of Kentucky. They since had moved to Austin, Texas. And so it's kind of this American story of a small business making a big impact. They provided the design features of this device to freely available to other companies. And then we've assisted other companies to get emergency use assurances from the FDA so that the availability of the devices wasn't limited by the limited number of manufacturers. And I can say that helmets now have been sort of distributed worldwide now. Before the pandemic, I would say the Italians and the French were commonly using helmets and the University of Chicago. And now I've seen helmets being used in Africa and in Asia. Places that have limited resources are using this for patients to prevent them needing ventilators.
And I would imagine too, the fact that you can, your typical hospital room in the United States usually does have some type of oxygen line or oxygen source in it. So the fact that you can hook this directly up to the oxygen line gives you, effectively some expanded ICU-like capability in a way, without having the true power of an ICU room.
Yes.
So some of the questions that we're starting to get, and I can tell these are doctors in the house. One question is, why do patients seem to do better on their stomachs versus their backs when they're being treated for COVID-19, in your experience?
Yeah, so a lot of the inflammation that we see and the distribution of the damage can be in the back part of the lung. So when you lay on it, more blood flow goes to the back. And so now you're sending blood to the area that's damaged. And so often when you sit forward or lay on your stomach, now blood flow is going to the front part of the lung, which may not be as affected. And so you're actually sending the blood flow where it needs to be. The second reason is when you're laying on your back, that part of the lung actually gets squashed, for lack of a better term. And so when you actually lean forward or sleep on your stomach, there's less, the lung can expand better, and these patients can have a dramatic improvement of their oxygen needs.
One additional question on the therapy side, Dr. Rattain, is immune plasma therapy being used to try to help patients at the University of Chicago Hospital?
Well, I mentioned that's the same as the convalescent plasma transfusion. So, there are studies ongoing, and the data that I've seen so far from these studies is sort of plus minus. I don't think we can rule it out yet, but I think that was sort of a stopgap approach. I think if this works, the monoclonal antibody approach, the industrial approach that Eli Lilly, Regeneron, and some other companies are using is going to be much more scalable. And so I personally am not that enthusiastic about the convalescent plasma transfusions.
And is the reason why you're not is the basic reason though, just in terms of it's hard to get the supplies, it's hard to make sure that you're actually going to have something available? Or, I mean, as a stopgap measure, is it, have you seen efficacy with it?
As I said, the randomized trials have not provided, you have to look under a microscope to find a signal, positive signal in the randomized trials. And so, yes, some patients get better, but we don't know that they got better because of the plasma. And the other issue is that we don't really have reliable tests to know if somebody who's getting plasma is getting plasma from that actually contains antibodies that work. Whereas the pharmaceutical approach, where everybody gets the same antibodies, it's either going to work or it isn't, but at least there'll be some consistency and predictability.
Got it. Could you give us some background, either of the doctors, on the regimen that involves hydroxychloroquine and the Z-Pak, azithromycin, plus zinc in some instances? If a patient requests that as a therapeutic, would the University of Chicago Hospital be willing to prescribe it, or doctors at the hospital be willing to prescribe it?
Well, let me take that one. So
I thought you would.
Well, back in March, we knew what everybody else knew, which is not very much. There certainly some laboratory evidence that hydroxychloroquine and chloroquine have antiviral activity. The question is, does it have enough? In other words, you can hear that a drug works in a culture dish against a virus, but what you don't know is, does it work in a living organism at doses that won't kill the living organism? And so no one had done any studies to show that hydroxychloroquine worked in any animal model of COVID, and people just started giving the drug. When we looked at the data, we said, there's some potential here. And there's a right way to do it and a wrong way to do it. And we thought that if it was going to work, we probably needed a higher dose than what others were using. And we actually tried to do a clinical trial, giving high dose of hydroxychloroquine for 5 days, because we thought that was the only chance of the drug working. And basically, we couldn't get patients to agree to go on that study. And because it just became so politicized, and that patients were saying, oh, I don't want that drug. And so we abandoned the trial. And so that's a long answer to the question. I think at this time, we would not give hydroxychloroquine outside of a clinical trial. And we have no clinical trials of hydroxychloroquine at this time.
Got it. I understand. Well, just out of curiosity, Dr. Patel, with the success of what the University of Chicago has learned in treating COVID-19 patients, has the death rate of the hospitalized patients been decreasing from March through to now?
Yeah, so that's a little bit of a challenging question to answer because in the beginning of March, the surge of patients was leading to, at one point in the ICU, we had about 50 to 60 patients in the ICU with COVID. And so the death rate of those patients was, a little bit over a quarter, but most of them were, needing the ICU for oxygen levels. Right now, we're dealing with patients in the hospital at much lower numbers, but they typically come in with other problems that happen to be COVID positive. And so then, right now I'm actually in the ICU, and we have about 35 patients. And of those, only about 3 or 4 have COVID. And in terms of whether they had pneumonia or not, not all of them have pneumonia-related reason to be in the ICU. So the death rate has gone down, but it is primarily because people are coming in and they happen to be COVID positive, but they aren't necessarily having a COVID-related complication.
Well, that's actually really interesting. So, when, was there a point in time where you kind of started to see this drop off of patients when they were coming into the ICU? It was for, I have a disease or a symptom that's X, but I'm also happening to be testing COVID positive, as opposed to, I think I have pneumonia that is a consequence of a COVID-19 infection?
Yeah, so it's summertime in Chicago, and a lot of the COVID patients that we've had recently in the ICU, not necessarily in the medical ICU, but in the surgical ICU, have been patients who um, um, underwent some sort of trauma and needed surgery related to that. And so they happened to be COVID positive, but they had, an injury that needed hospitalization. So there's been less. I would say we closed down our COVID specific ICU at the end of June. I actually was caring for patients in the unit when that closed, which felt like a relief and a breath of fresh air to leave the pod and be out with the other living. And our numbers in the ICU had gone down to single digits. And at one point we had at the end of June, no one in the medical ICU with COVID, which was really great to take care of what we used to take care of. Now the numbers are trickling up again, which is a bit disheartening. But we've also learned more about COVID, that we've gotten a bit more experience so that we don't have the pitfalls that we had before. So, for example, we are using remdesivir. Patients who need oxygen, we're giving them a steroid called dexamethasone. It's a once a day pill that you take for 10 days. And I've significantly seen a difference. Patients who came in quite sick that I would lose sleep over at night, they would get remdesivir with the dexamethasone. And I have a patient in my care right now, and she's needing less and less oxygen every day. And so that has been great to see, because previously back in March, we were doing what we could to manage the symptoms and hoping that the body would resolve the infection, try different drugs through clinical trials and all that. But it was really hard to see kind of big successes. And now I'm seeing a difference with remdesivir especially, and then also with the steroid.
One of the questions that came in, are there, when it comes to testing, are there tests with combinations of influenza and COVID that you're aware of? Dr. Ortain, this is maybe more on the diagnostic side for you. I know testing is starting to actually become much more of a challenge.
Well, I think that when influenza comes back in the fall, I think patients will get routinely tested for both. It's not going to be a single test. It'll probably be a single swab, however, that can test both. We may be doing salivary testing routinely by then. I think that's what people would like to be doing.
Right. One of the other questions that I'm kind of curious about is, Dr. Patel, since you've seen this, I mean, it's great, right, that you've been able to actually close your COVID-specific intensive care unit. One question that we as policymakers are always trying to deal with is the hospitalization rate, and are we going to run out of hospital capacity? With some of these new cases that have been coming in, have there been any alarm bells going off that we're going to have some big second wave that we might not be able to manage, or are people feeling comfortable with their current ICU and hospital capacity?
Yeah, I think paying attention to the hospital beds available is a good marker, because I think the thing people forget about is, COVID's not the only problem patients can have. When you have cancer that needs to be treated or diagnosed, or you need a transplant, if the beds are filled with COVID patients, then you can't get those other life-saving things. So right now, our ICU, typically in July, has about 25 or so patients before COVID. And right now we're sitting between 35 and 38. And like I said, not many of those patients have COVID. What I have found is that because people may have been delaying their care because hospitals have been full and clinic spaces have been limited, I think we're seeing that spike of other medical conditions worsening because of access to care. So as we think about the fall, typically this type of virus, the coronavirus, the common colds, but specifically this one strain, does recrudesce at the winter time. And that seasonal variation, I think we have to be prepared for, because at the same time that we want to do all the measures to kind of limit community spread, we really want to keep our doors open to people who may have heart attacks, people who have strokes, people who need treatment for their cancer. And so right now, we're seeing a big use of ICU beds because of the delayed care of non-COVID medical care.
Yeah, I've gotten that feedback from quite a lot of doctors and nurses as well, that, now they're starting to see the patients coming in the door. Well, oh, you should have probably been put on this medication 6 months ago, and now, your condition is deteriorated, and, there's a lot more interventionalist medicine that needs to be done.
Yeah.
One question, since you're talking about the fall and what can we expect to see, obviously, not only is fall the start of flu season, but fall is also the start of the school year. So one question that I am getting constantly, we have many parents who want in-person education. Would either of you send your children or grandchildren to school this fall, knowing what we know currently about COVID?
Well, I have no grandchildren, and so it's easy for me to answer. I think the issue is if your kids are going to school, you're at high risk of getting sick yourself. So I think, yes, there's a risk the kids themselves could get very sick. I don't think that's what most of the concern is, because kids get very sick rarely, but for a variety of reasons. I think the biggest risk is to the parents, and that if you're going to send your kid to school, you should assume that they're COVID positive, and that's kind of tough to manage in a home, and so that's the real challenge. And a colleague of mine told me the other day that his nurse just was diagnosed with COVID. She didn't get it at work; she got it from her child who was in daycare. And so now imagine if, she had been at work and transmitting it to other patients. And I think that's where things start to get pretty scary, when healthcare providers may be sending their kids off to an environment where the kids are bringing it home to the healthcare provider, and then the healthcare provider is at risk for giving it to patients and colleagues. So that's the kind of concern I have.
Now, one interesting, issue that's come up is there are several, either the kids or the parents, they tested COVID positive. They went through the quarantining process, and either a family member wind up not testing COVID positive ever, or maybe they were positive. It's just their innate immune system kicked it out before it could be detected. So, for those students, say, the family household has already been exposed to COVID, they've gone through quarantine, and they've come out the other end. Does your answer change when you're talking about those types of parents or students, as opposed to people who you might say they're COVID naive in terms of exposures?
Well, I think from a medical perspective, it would. From a parent perspective, it would. I don't know how it would change from a school perspective and a political perspective and a governance perspective, but I think you are correct. I think if one's already had COVID, one would not have the same fear of getting COVID that somebody who's not had COVID would have.
Right. Now, one thing that you did mention is you said that, you should assume if you send your kids to school, they're going to wind up COVID positive, and so will you, or at least, COVID, maybe we should call it COVID exposed. Do you think that the social distancing measures that are being proposed for classrooms are going to make much of a difference? If you've got a COVID positive teacher, or you've got a COVID positive student in the classroom for 6 hours a day, even if you're wearing masks, or, people are trying to stay 6 feet apart?
Well, I don't think there's a simple answer to that. The one thing I've learned recently is not all masks are created equal. And so there are some big differences between masks. I just read about a mask that's being manufactured by a Swiss company that actually has a layer in the mask that kills the virus, supposedly. And they're seeking FDA approval for that mask, although apparently you can purchase it in the United States. But it's a 3-layer mask that supposedly kills the virus. It's also, however, pretty smart business concept. You can only wash it 30 times, and you have to get a new one. And guess what? It's not a cheap mask.
What a shocker. Dr. Patel, just out of curiosity, what did the University of Chicago do to try to prevent burnout amongst its physicians and nursing staff, given, the added stress levels that they had to endure, the risk? I mean, you indicated that you were staying in the pod and, really trying to stay isolated. What types of techniques were working for you to get through that?
So the University of Chicago tried to do a lot of resilience training. So there were some exercises that we do with a psychiatrist to kind of, as you put your mask on, your PPE, and walk into that space, it's hard not to feel a little bit of trepidation, especially when you don't know what this could mean for you and your family. And so we would do sort of meditative moments. When you were in the pods, you kind of, everyone who worked with you, you were in this kind of other world, and you were there together. So that camaraderie helped. But I will say, I was so busy that I didn't have the time to check in to my own psyche or fears. And it literally was the day that we ripped down the final door of that pod that the weight that I had been carrying fell, like I felt it for the first time. And I will say, I'm not looking forward to the fall. And I really hope that, I know it's hard to, believe that it's happening, because most of the crisis is behind these closed doors and closed COVID ICUs or closed COVID hospitals. But the reality is that it is happening. And, I think that if people continue to take care of not only themselves, but think about the community, kind of practicing social distancing, masking, washing hands, not doing high risk activities. It's not just about your health, but it may be, interact with that grocery store person who then has a vulnerable person at home. So it kind of, that weight has been hard. Things that have helped outside of work and my colleagues has been my child, having some comic relief, coming home from a hard day, having the feeling like, the weight's on your shoulder, and having him just laugh and, play around. That gave me a little bit of levity, that in a time where, it was hard to know what the next day was gonna bring. So if anything, it's taught me, not having the ability to do all the fun things that summer in Chicago could do actually showed me to appreciate the little things like my child and my family and my health. And also be thankful that I could contribute something at a time when there was a lot of uncertainty.
Beautifully said. Thank you for that. Dr. Chain, let's go back to some of the clinical protocols. Obviously, again, as we're going into the fall, as we're looking towards what does the future hold, one of the issues that's obviously come up is there going to be a vaccine? And there's a whole bunch of different protocols and platforms that are currently out there. What are your thoughts on, is it realistic to expect we're going to have a COVID vaccine anytime within the next 2 years, going through the safety and efficacy phase 3 trials with FDA approval?
I think we'll have a vaccine within 2 years, but the question is, how effective will the vaccine be?
Right.
Okay. And what's effective enough that people will feel comfortable? And, if it's 80% effective, is that going to be good enough? Will that make people just go, oh, well, I'm not worried, I got the vaccine? And I think what we really need is a combination of effective strategies. And so a vaccine would be great. Having remdesivir fully approved and with adequate global supply would be great. The company has filed for FDA approval. The issue has not been whether, if people believe it's safe and effective, the issue has been whether there's enough drug. And the company has recently said that by October, and I suspect that'll be October 31st, there will be adequate drug supply for the world. And hopefully they're assuming some worst case scenarios there. And so I think that will be important to have an FDA approved drug that if somebody gets sick, they know they can go to the hospital and get that drug, and that drug is highly effective if it's started early. If you wait till you need a helmet, or even worse, a respirator to go to the hospital, remdesivir is not going to do the trick by itself. And you're going to need to be at a place that has a lot of experience, and you'll have to do a lot of praying as well. And so, but it would be nice to have an oral drug so that if the vaccine fails, you have an oral drug. If the oral drug fails, there's remdesivir. And so if we had a few different therapies, each that worked 80% of the time, we'd be in pretty good shape.
You know, and one thing, you know, you mentioned the issue of actually manufacturing enough quantities of remdesivir. You know, the antivirals have notoriously been, you know, lengthy synthetic schemes. You know, they're delicate molecules. They can decompose pretty easily. If you know, because of some of the particular substituent groups, some are pretty reactive. Some look like biological molecules, so they're easy to degrade. You know, so I think that's one of the underappreciated parts of it, and it's going to be true with the monoclonal antibodies as well, is that the chemistry and the manufacturing capacity to actually make these molecules is incredibly sophisticated, and you know, it's not something you can just kind of whip up in your basement or on a lab bench. One question for you know, for the doctors, is there any patient criteria that you've seen that makes a person more likely to progress to a serious COVID case versus a mild case?
Well, I would say there are. And so we don't fully understand it, but, you know, patients with chronic diseases, and particularly patients that have higher levels of inflammation or diseases that are associated with higher levels of inflammation, are at greater risk of progressing to the hyperinflammation syndrome of COVID, which is really what is killing patients. And so, or of course, just delaying seeking medical attention. So if somebody, you know, gets COVID and is, you know, has clear pneumonia but doesn't seek medical attention, they're going to have a lot of problems no matter what their prior health was. Whereas somebody that is in fairly poor health but gets care early, and their other, you know, they may do better. So I think it's really important to get care early if you develop COVID and you develop any significant pulmonary symptoms. And as Dr. Patel said, you know, you can buy one of these pulse oximeters at a pharmacy. And if somebody is worried about getting COVID, and I've advised patients of this, to get a pulse oximeter, particularly if they have any underlying lung disease, and just check it, because your oxygen could be going down with COVID and you wouldn't know it. And so just like one might be concerned about following someone's fever, your blood pressure, you can follow your oxygen as well.
Yeah, and that was actually one of my related questions: is are there symptoms that people should be looking for? So, you know, maybe I suspect I was exposed to COVID. Maybe I don't know that I've been exposed to COVID, but that are some of those earlier warning signs that you may be a COVID patient and should start getting, you know, should start monitoring, or at least start going out for testing.
Well, I think it's the fever is probably the patients that, you know, that seem to do the worst are those that really are getting these very high fevers. And that's a sign that the, you know, hyperinflammation may be starting to set in. Now that can be, you know, the remdesivir can get a handle on that disease if it's not started too late. But it's, you know, fever plus shortness of breath is certainly a reason to go to a hospital.
Right.
Yeah.
And Dr. Patel, I think you were talking about the happy hypoxia patient. So can you explain what that is?
Yeah, so often patients when they have normal oxygen levels are like 100%, 95 plus at least. And often when your oxygen level goes to 80% or so, you should be feeling short of breath. You should be breathing fast, kind of feeling like you're can't get the air that you need. And often these patients would come in unaware that their oxygen level was that low. They'd be breathing a normal pattern of breathing, have a full sentence of conversation, and you check the level of their oxygen and be 75%, 60%. And they were unperturbed by it. And that's why these devices to look to see if your oxygen level is low is helpful. Other signs that you might experience are body aches. An unusual feature can be you lose your sense of smell. And then interestingly, some of the risk factors for a severe COVID infection are kind of garden variety medical conditions like high blood pressure and diabetes. And so often patients now that we're seeing with COVID, if they don't have pneumonia and shortness of breath, they're having out of control diabetes events. So we have some patients in our ICU who need insulin through the IV because their sugars were undetectably high and they turned out to be COVID positive. Another unusual symptom that we've been seeing is that patients' blood can get thicker and clot. And because of that clotting, they may come to the hospital with a new stroke, young people in their 40s with a new stroke. So any symptom like new weakness that's kind of on one arm or one leg, slurred speech, those sorts of things should bring you into the hospital because it could be related to COVID.
And Dr. Attain, I think, Dr. Patel mentioned the loss of the sense of smell. I think some patients have also reported a loss of taste. That I believe there was some theory floating around that maybe that might be a rationale to include zinc supplementation, or that was one of the rationales for trying to put zinc in connection with the hydroxychloroquine regimen under the theory that, a zinc deficiency can also lead to the loss of taste or smell. Has that been validated at all?
No, and I think this is a virus that likes to infect nerve cells, and so it infects the nerve cells that are involved in smell, taste, and some patients are having prolonged loss of taste or loss of smell.
And one other thing that I've heard from people who, again, maybe they test, or they were living with a family member who tested COVID positive. They've had symptoms associated with COVID, yet they've never tested positive in a test. Is that something that either you or Dr. Patel that you've come across in your experience?
Definitely.
And if so, what's driving that?
Yeah, I mean, I've definitely had patients that I certain had COVID. They didn't get tested because I just said there's nothing we're going to do with the test result, and then sent them later for antibody testing and it was negative. So I mean, I just, there's a lot of issues with the testing, and just like any test, there's false positives, there's false negatives, and no test is 100%.
Right. I mean, even with the PCR test, there were some concerns that you might actually be detecting some old, just some regular cold viruses that you might have previously been infected with, or, maybe you were getting tested and that you were thinking it was a live virus when in fact your body had already gone through it and this was just viral shedding. Is there anything, in terms of a takeaway, whether someone is a doctor or a potential patient, when it comes to some of these clinical symptoms? Are there things that people can do, to try to be proactive about their health? We've all heard about the mask, the social distancing, but are there things that people can do to just try to make their bodies and their immune system stronger and healthier, so that if they do become exposed to the COVID virus, they'll be in a situation where their innate immune system can kick it out and they'll be fine and hopefully not progress to some of these more serious conditions?
Well, unfortunately, this virus attacks the innate immune system. But one of the things that we believe and are planning studies is with vitamin D supplementation.
Yeah.
So that is, and I'm taking vitamin D myself. So so that's one thing that people can do. I think the other thing is to do your own research regarding masks. It's definitely don't use a homemade mask. I mean, it's better than nothing, but there are differences in masks, and I don't claim to be the expert, but there's a fair amount of stuff written about it from reliable sources. And so not all masks are the same. And I think that's important for people to keep in mind. And the third thing is in the fall, come September, make sure you get your flu shot because you don't want to get influenza. You may end up in the hospital with influenza and then get COVID while you're there. So that's the last thing you want to get.
Right. Dr. Patel?
Yeah, I have nothing more to add. I put it this way, we'll be busy in the fall and I don't want to see you. So, and the best way, you know, we can think about all the treatments and things like that, but I'd rather you just not get it. And the reality is because we don't know what it means. Some people are asymptomatic, but then later have other problems. And so it's important to think about that. I think vitamin D seems promising and doesn't seem to have much of a downside to try. Beyond that, I hope we find more, of course. And I think we're finding how to put a Band-Aid on something that's already really sick. But I think the next frontier is preventing people from getting sick in the first place.
Absolutely. You know, in the vitamin D, I know, Dr. Tan, I believe there was an Israeli study. There was one coming out of, was it Thailand? Another one from, maybe it was Venezuela. You know, I know that there have been a lot of vitamin D studies, which I thought was intriguing because I was curious if that might even contribute to some of to a potential cyclical effect like we have with the flu season as well.
It's hard to say. I mean, there's, you know, there are theories about allergies and how that plays in here. That you know, in allergy seasons that COVID goes down. You know, there's lots of theories, but as far as I've seen, no one's done a randomized trial yet of vitamin D supplementation, and that's what my colleague David Meltzer is hoping to do and seeking funding for that study right now. And I think that will be important if we can show something as simple as vitamin D does at least prevent, whether it will prevent you from getting infected, which is one possibility, or just prevent progression to severe disease, that would still be a benefit.
Absolutely. So I do want to, you know, just kind of say last call for questions. You know, we've had fantastic expertise from our panelists here. So I do want to make sure that everyone who's on the call has access to them and gets their questions answered. So you can either type it in the chat box or type it in the Q&A session so that I can make sure that we get to that. So while we're doing our last call for questions, I'm going to go to the next slide for those who are watching. If you are looking for places where you can get tested close to the 47th district, the closest locations, according to the next slide, there's one in Aurora, one in Harwood Heights, one in Rolling Meadows. And also, I'm extremely proud that the DuPage County government has made a point of also having free COVID testing at the DuPage County Fairgrounds. If you want updates on that, you can visit repmazzochi.com. So repmazzochi.com. Click on COVID-19 info, and we are trying to keep those particular details updated as quickly as possible. All right, so I do want to again say last call for questions. Here we go. CDC released guidelines with a heavy emphasis on getting students back into the classroom. Their guidelines lay out the social, emotional, and mental risks of keeping students at home. How, as a medical professional, do you compare the potential risk of students getting COVID versus the more likely chance they will suffer some of the emotional and mental risks that the CDC is concerned with?
So, you know, I think, obviously, I think everyone's in violent agreement that, you know, everyone would love for kids to go back to school and for it to be safe for the teachers, for their parents, and whoever's in their homes. I think that in districts where the community spread has been brought down to single digits, where you can easily do contact tracing and figure out who's been exposed and not been exposed. We've seen schools open in Europe when they brought the cases down to this controllable number. and able to open schools in a way where they were embracing social distancing, hand washing, having face masks, and then also even guards on each desk. And, they've been able to demonstrate that they can open safely, but it was in a context where the community spread was under control. So I think that, I don't want to delve into a political space or, put any sort of thoughts about or overlay any opinions on that. But I think it sometimes ends up being an individual choice, because I know that there are other balance things that people have to weigh against the children's mental health and well-being related to being back in school and being with their friends, parents needing to go back to work. As a mother of a young child who was in a very busy time, we had to make hard choices about my husband was busy, he's an OB, and I was a pulmonary doctor. Two things in a pandemic that don't change: people get sick and need a ventilator, and people get pregnant and need to deliver their babies. And so I can imagine the stress that's on families when they're trying to weigh these options. What I can say is that putting trust in your local governments to ensure that the community spread is under control, and that the local districts are doing the things that, at least to mitigate the risk of exposure, can kind of weigh in your decision to send your child back to school.
Thank you for that. Well, we are close to our end time. So again, hopefully we've been able to answer all of your questions. I think we managed to get to everybody. If you do have any other questions that we didn't manage to get to tonight, or if you think of something further, please do feel free to reach out to our office. My email address is Mazzochi, Mazzochi, at ilhousegop.org. You can also, again, find us at the website, repmazzochi.com, or come by to our office at the Westmont Center. I would encourage anyone to sign up for our newsletter, because that's the best way to get more detailed information on what's going on in the district. And you can also like us on Facebook, which is Illinois House 47, and we are giving people daily updates. So again, I do want to thank so much our wonderful panelists for tonight, Dr. Mark Ratain, Dr. Bhakti Patel from the University of Chicago. Thank you so much for the wonderful work that you do. And on behalf of the people of the state of Illinois and in our district, thank you for the incredible work that you've done so far to take us so far down the path to COVID recovery and making sure that our patients are being well taken care of, and doing everything you can to make sure that we can beat this and stay safe. So thank you very much, everyone. Thanks so much for joining us. And we will have a copy of this webinar available on both our Facebook page and on the website. Thank you so much. And thank you to the University of Chicago as well for sharing your time with us.